And our final abstract will be presented by Alexander Moran. Mr. Moran's presentation is entitled Maternal PrEP Use in HIV-Uninfected Pregnant Women in South Africa, the Role of Stigma in PrEP Initiation and Persistence. Mr. Moran is presenting from the University of California of Los Angeles in the United States. Thank you.
Hi, everyone. I'll be talking about maternal PrEP use in HIV-uninfected pregnant women in South Africa, specifically the role of stigma in PrEP initiation and persistence. We know that biological and behavioral factors contribute to increased HIV risk among pregnant people. We also know that HIV pre-exposure prophylaxis is a safe, effective, and user-controlled HIV prevention method recommended by the WHO for use among women at high risk of HIV, which they define as incidence of greater than 3 per 1,000 person years. Despite these increased risks and the availability of chemoprophylaxis, uptake of PrEP among pregnant people in South Africa remains low despite the provision for PrEP among pregnant women in government policy as of September 2019. In light of this, we studied the role of anticipated stigma and internalized stigma in PrEP initiation, retention, continuation, and adherence in a cohort of pregnant and postpartum women in South Africa. The PrEP-PP, or PrEP in Pregnant and Postpartum Women study, is an open prospective cohort with a planned sample size of 1,200 participants, of whom 633 have been recruited as of 9 September 2020. The baseline visit includes testing for sexually transmitted infections, HIV, and creatinine clearance for PrEP users, and a survey with questions on sociodemographics, relationships, risk perception, partner serostatus, intimate partner violence, substance use, depression, and stigma. PrEP users are given 1 month of Truvada at baseline, return for a 1-month follow-up visit to collect an additional 2 months of PrEP, and everyone regardless of PrEP use returns for a 3-month follow-up visit. We measured 4 outcomes. The first was PrEP initiation, defined as receiving a PrEP prescription at baseline. We included 623 participants. The second was PrEP retention, defined as returning for 3-month follow-up. We included 418 participants. The third was PrEP continuation, defined as initiating PrEP at baseline, returning for 1-month follow-up, and continuing on PrEP through 3-month follow-up. We included 221 participants. The last outcome was PrEP adherence, defined as continuing on PrEP through 3-month follow-up and taking PrEP for at least 25 of the last 30 days, measured by self-report. We included 175 people in this outcome. For stigma measurements, 6 stigma questions loaded into 2 scales of 3 questions each. The first was internalized PrEP stigma with an alpha of 0.811, where an example question is, I feel ashamed of using PrEP. The second was anticipated PrEP stigma with an alpha of 0.777, where an example question is, I think people will judge me negatively if I take PrEP. As far as analytic methods, we used R to run simple and multiple logistic regression and define 2 multivariate models. The first considered internalized stigma and controlled for gravidity, education, gestational age at baseline, and STI at baseline. We controlled for STIs only in the adherence outcome. Similarly, we considered anticipated stigma and controlled for gravidity, education, gestational age at baseline, partner HIV testing or knowledge of serostatus, and STI at baseline, which we only controlled for in the adherence outcome. Our descriptive results are baseline measures collected at the first antenatal care visit. Median maternal age was 25 years with an interquartile range or IQR of 22 to 30 years. Median gestational age was 21 weeks with an IQR of 14 to 29 weeks. Median gravidity was 2 pregnancies with an IQR of 1 to 3 pregnancies. 27% of participants had a partner with unknown serostatus, 35% of participants had an STI at baseline, and 91% of participants initiated PrEP at baseline. We found that women with high internalized stigma were at significantly lower odds of initiating PrEP at baseline compared to those with lower internalized stigma, even after controlling for gravidity, education, and gestational age. Similarly, we found that women with high anticipated stigma were at lower odds of PrEP initiation at baseline compared to those with lower anticipated stigma, even after controlling for gravidity, education, gestational age, and partner HIV status. Not shown here is that high anticipated stigma was also associated with lower odds of PrEP retention at 3 months compared to those who had low anticipated stigma, and the participants who did not know their partner's HIV status or whose partners had not been tested were at higher odds of retention compared to those whose partners had been tested for HIV. Among those who continued on PrEP for 3 months, we found that those with lower education had higher odds of good adherence compared to those with higher levels of education, that those with higher gestational age at baseline had lower odds of good adherence, and that those who had an STI at baseline were at lower odds of good adherence compared to those who did not have an STI at baseline. Based on these results, we found that within PrEP initiation, high internalized or anticipated PrEP stigma is associated with lower PrEP initiation among pregnant women at first antenatal care visit. Within PrEP retention at 3 months, we found that high anticipated stigma is associated with lower PrEP retention at 3 months, and that unknown partner serostatus or a partner who had not tested for HIV is associated with higher PrEP retention at 3 months. Finally, within PrEP adherence at 3 months, we found that among those who continued on PrEP, those with higher gestational age at baseline and those with STI at baseline have lower odds of good adherence at 3 months, and that among those who continued on PrEP, those with education less than grade 12 have higher odds of good adherence compared to more highly educated participants. From this, we see that PrEP stigma can act at multiple steps in the cascade of care, with internalized PrEP stigma acting on PrEP initiation and anticipated PrEP stigma acting on PrEP initiation and PrEP retention. Among those who continued on PrEP, additional factors are important to good adherence, including STI testing and treatment and early engagement in antenatal care. Normalizing PrEP use in the community and encouraging PrEP counseling and information dissemination may reduce internalized stigma as a barrier to PrEP initiation. Finally, offering PrEP to women at high risk for HIV and engaging male partners in testing strategies may reduce anticipated stigma as a barrier to PrEP initiation and retention. We'd like to thank our study participants, the PrEP PP study staff, and the City of Cape Town Department of Health staff. Thank you very much.